At that month 7, we could tell that he was kind of having some breathing issues. Jordan was in the NICU for 8 months. He was 8 months old when he passed away. He had chronic lung disease. On the actual death certificate and the cause of death, it said his heart eventually gave out. One baby dying is too much. One mom dying is too much, and we see it every single day.
Southern Remedy is underwritten by a grant from the University of Mississippi Medical Center and viewers like you. Thank you.
At 24 weeks along, Natoya Sanders thought she was enjoying a healthy pregnancy when she went to the emergency room because of a severe pain in her side.
So I would later find out that my blood pressure was on the extremely severe end. I'm a preeclampsia, and it was at that point that I was transferred immediately to UMMC. The path that we thought that we were on is to give me steroid shots, to constantly take sonograms and watch ultrasounds and, kind of monitor Jordan's progress, and to be on bed rest until I was 36 weeks pregnant.
That would mean 12 weeks in the hospital, but
we found that Jordan's growth was restricted, and that could have been because of my blood pressure and the blood not being circulated to him. So even with the steroid shots, he wasn't growing. And it seemed like in the blink of an eye, things changed, and they said, okay, well, we're gonna have to do surgery, within like the next 24 hours or so. There's about a 10% chance that he would survive. I thought a premature baby was a baby born 4 or 5 pounds. I had no idea that a baby could, be born at 1 pound, 1 ounce. They didn't get to hold him or see him. They took him straight to the NICU. I went into recovery for about 2 to 3 days, and then I was able to be wheeled down to see him. But I wasn't sure if I wanted to go in and see him because I felt if I got attached to him. It was terrifying, to say the least. I barely talk about those, situations, or I guess the events surrounding, especially those first few days. He was very critical.
One of Jordan's early challenges was surgery to close a hole in his heart.
It really did save his life because he was able to be extubated, and he got off the ventilator. I was actually able to see his little face, really good. And it was, those are tough times, but those were the best moments of our lives.
Natoya stayed with Jordan every day for 8 months. Eventually, their doctor had a critical talk with the family.
He gave us the facts, and that's exactly what we asked for. We knew at that time that there were going to be some really hard decisions that we were going to have to face, over the next few weeks. Little did we know that very weekend is when Jordan passed away.
Preeclampsia, defined as high blood pressure coupled with protein in the urine, caused Natoya's problems.
We've known that it can affect a mom's long-term health, but many times it results in an early delivery, and that is a major contributor to preterm birth in the U.S. and then particularly in Mississippi. Moderate risk factors include things like being obese, being African American, having low-range high blood pressure.
Approximately 30% of preterm births in our state are due to preeclampsia and hypertension, but not all early deliveries have tragic endings.
We are very good at keeping very preterm babies alive in the U.S. Babies who would otherwise not even have a chance in many other countries are able to survive. The advances in technology are incredible.
Carter is a 3-year-old. He's no longer considered to be measured or viewed on the preemie chart anymore. He was taken off of that at 2 because he was over the weight and height. He's tall, he's active.
Keisha Flanagan was enjoying what she thought was a perfect pregnancy when a routine checkup revealed high blood pressure. Her doctor sent her straight to the hospital. That was in November.
I wasn't due until Valentine's Day. I was gonna be on bed rest from then until my actual due date.
But with her blood pressure rising and an uncontrollable cough, doctors ordered more tests.
The results showed that I had walking pneumonia and that my kidneys were failing. And that was the same day that I delivered, maybe 2 hours later.
Carter Flanagan was born via cesarean section on November 7th after gestation of only 26 and a half weeks. He remained in the hospital until February.
Those are 105 days I will never forget. It started out very rough. Very rough. We had 2 scares. The moment he became 2 pounds, every doctor's appointment, checkup, we've been told he's doing well, he's fine, he's right where he needs to be.
When a baby is born that early, or any time less than typically 32 weeks, they're at the highest risk of complications.
At 26 weeks, the lungs are not mature compared with a baby born at 32 weeks. As such, the baby will need significant respiratory support, and we want oxygen in the body and carbon dioxide out. If the lungs are not mature enough to exchange that the way we should, that means every other organ is not getting oxygen the way they should. When the heart doesn't get oxygen, it gets tired. It doesn't work well. The kidneys may shut down. The bowel may have what we call necrotizing enterocolitis, which is one of the most deadliest infections in the newborn that kills babies.
In Mississippi, the most common medical reason for an early delivery is a combination of diabetes and hypertension in the mother.
They end up with complications related to these illnesses, and for the sake of the mom and the baby, many times the baby needs to come out. I must emphasize that maternal health is a major, major, major contributor to the preterm birth that we see in our state.
The March of Dimes gives Mississippi an F on its 2018 preterm birth rate report card. At 13.6%, our preterm birth rate is the highest in the nation, a full percentage point above neighboring Louisiana and Alabama, and more than 3.5 points above the national average. And among Black women, this rate is 44% higher than among all other women.
Even though women may achieve higher education or be out of poverty, we still see higher rates of preterm birth in Black women.
There are some situations where it's the family situation at home. People living in hostile environments, in food deserts, the contribution of poverty. And some have talked about the contribution of racism.
Those things sometimes take you outside of the hospital, outside of clinical practice, and looking at health as a whole, which gets into factors that go far beyond clinical care, like health, nutrition, access to services, education. But there are states who have reduced those rates to levels that are lower than some white women in other states. So I'm just trying to make the point that it's not just about race or skin color, that healthcare systems, communities, states, people can achieve a higher level of health. They can have better outcomes, and it's not just about race. Hello.
And healthy babies will help everyone.
Looking at it from a population health perspective, one preterm infant costs the state a whole lot more than taking care of a bunch of healthy term babies in the Well Baby Nursery.
Nearly half of very early babies die on their first day. According to the Centers for Disease Control, Mississippi has the highest infant mortality rate in the country. And the United States has one of the highest rates among the world's developed nations.
In Mississippi, about 2% of babies are very low birth weight, or less than 1,500 grams, less than 3 pounds, but they contribute to about half of the deaths.
What is killing our babies before they reach their first birthday? Statistically, birth defects, preterm delivery coupled with low birth weight, sudden infant death syndrome, and pregnancy complications top the list, but there are other factors.
Access to a provider during pregnancy is very important, and knowing that many women in Mississippi have to drive over an hour to see a provider during their pregnancy is concerning and a major challenge for our state. What this means for a woman is that every time she has to see her doctor or provider, she has to take off of work, she has to find childcare, she can't get care when she has one of those minor complaints that many moms are concerned about.
Approximately half of Mississippi's counties are maternity care deserts, meaning no hospitals offering obstetric services and no OB/GYNs.
The solution is, of course, more providers, and this goes in a couple of different ways. It is more OB/GYNs and physicians who can provide the full extent of care. It's also more midwives in our state.
All of this results in an infant mortality rate of 9 deaths per 1,000 live births annually in Mississippi. Our national rate is 5.9. Dr. Michelle Owens and Kira Johnson both enjoyed healthy pregnancies and carried their babies to full term. But shortly after delivery, Dr. Owens nearly died.
I am a survivor of a very significant postpartum hemorrhage. Had some mild elevations of blood pressure afterwards, but nothing really significant. And I had gone home.
As she went to bed, there was a big gush of blood, followed by another.
The blood kept coming, and it got more and more brisk.
She knew to get to the hospital.
I've ruined my clothes, and I'm heavily bleeding. And I just remember the look on the face of the nurses when I came in and they laid me on the table. I said, I really think I'm gonna need to go to surgery. They had tried some medicines. The medicines weren't stopping the bleeding. When I woke up, I had received multiple transfusions. And fortunately, my doctor and my team at my hospital, the people that I've been elbow to elbow with for years, had managed to save my life.
Every single thing that could have went wrong in the care of my wife after the delivery of my son did in fact go wrong.
Kira Johnson went to the hospital for a scheduled C-section. She kissed her firstborn son goodbye before she was wheeled to delivery.
Hey, Langston. I've been waiting on you, buddy. Everybody's here to celebrate.
In a matter of hours, she was dead.
Shortly after delivery, we were back in recovery. I recognized that there was blood in the catheter, and they allowed Kira's condition to deteriorate for more than 10 hours. And she bled internally and suffered, while my family and I begged and pleaded for them to take action. Unfortunately, by the time they took Kira back to surgery, they found 3.5 liters of blood in her abdomen, and her heart stopped immediately. I thought that Kira was a complete anomaly, a woman that was in perfect health, delivering in a top-notch institution, losing her life. I thought there was an anomaly.
But it's not. There has been a steady increase in pregnancy-related maternal mortality since 1987. Nationally, over 700 women die each year from pregnancy or childbirth-related causes. Out of 47 states reporting numbers, Mississippi ranks 20th. And more mothers may die than are reported.
When you look at her death certificate, it simply says she died of hemorrhage shock. Nowhere on that death certificate does it say anything about her pregnancy or her death being associated with her pregnancy.
Some of the primary reasons for these deaths include hemorrhage, heart conditions, cardiomyopathy infection, embolism, mental health conditions, and preeclampsia or eclampsia. There are other reasons, too.
Part of it is age. More and more women are spending time on their career and doing several different things, which is not a bad thing. But that means the prime time when pregnancy should happen is being missed.
High blood pressure and preeclampsia in particular are major challenges as it relates to both maternal health, because it's a major contributor to maternal mortality.
Many of them do not know prior to pregnancy that they have these chronic illnesses. They go into pregnancy without being prepared.
Kira Johnson was prepared. She had enjoyed a healthy pregnancy and didn't anticipate any problems with her cesarean delivery.
When you see so many women who have had cesarean deliveries, and there are plenty of times when that's necessary, but it's still a very large surgery, and with surgery comes additional complications, and the circumstances surrounding how cesarean deliveries actually occur or why they occur may also further increase risk.
C-sections do contribute to a good portion of maternal morbidity as well. When moms have particularly multiple C-sections over the course of their lifetime, it puts them at risk for higher complications.
There's a need for more awareness about the significance of cesarean deliveries in general, because again, they have been somewhat normalized, recognizing that because they are bigger surgeries and they do increase risk, it's really important that women have reasons or indications for those deliveries.
Certainly we know in Mississippi, where we have one of the highest rates in the country, that there is room for improvement.
There are also provider reasons that mothers die. The CDC reports that lack of standardized policies, inadequate clinical skills, failure to consult specialists, and poor coordination of care are contributing factors. Beyond these are lifestyle considerations.
In most of the United States, and most physicians can't write a prescription for better nutrition or write a prescription for better housing, although those things would very likely lead to better health outcomes.
As with infant mortality, there is a distinct disparity in pregnancy-related deaths between Blacks and all other women.
We know that African American women are 3 to 4 times more likely to die due to pregnancy complications.
It is not just there's something wrong with this part of the population or these women, or there's something underlying in their biology that cannot be fixed.
It's very common for people to believe that these things happen because people are poor, or because people are uneducated, or because they don't have access to health care. There's an issue with bias that exists within the medical community and the way that healthcare providers perceive people's complaints. This has been proven all over medical literature. It's not just limited to obstetrics and gynecology. We know that women of certain ethnicities who present with the same complaints to emergency rooms are treated very differently.
Racial disparities, implicit bias, those honestly are long fixes. We've got a lot of work to do with implicit bias training and cultural shifts and sensitivity to correct those things. I think we even need implicit bias training as a mandatory piece for doctors that are currently in medical school.
I would love to see it incorporated into professional school training for anybody in a health profession. That's part of our legacy. We have all inherited that, even if we've not even contributed to it in some way, that is a legacy that we have inherited, and not to acknowledge those differences and to not understand that we might have biases, and not to be trained on those biases, and not to understand people who may not look like us or who may not live in the neighborhood like we live in, does us a disservice, and it inhibits our ability to truly deliver good, consistent care to every woman every time.
It will take both scrutiny and action to reduce the number of African American mothers who die due to pregnancy complications.
What does this population need, and how do we give it to them, and commit as a society that, yes, my taxpayer dollars are going to a program that's benefiting a group that's not me, but it's going to help improve outcomes. And I think that's a challenge that a lot of people aren't always comfortable with, but that's really what's needed.
Having conversations about maternal mortality and infant mortality, the data may seem very discouraging. The other way to look at it is it's an incredible opportunity. It's an opportunity for us to do significant things that will make big differences in the lives of moms and their babies.
I think it's important for people to know that we have room to improve for every mom in Mississippi, and any mom can be affected. The changes that we have to make in both our clinical care and our health of our population, so nutrition, education, poverty, safe neighborhoods, those are going to pay off for every mom. It's not about a racial thing, or one racial group has a problem and one doesn't. We have room to grow and room to improve for our entire state. Preterm birth, infant mortality, maternal mortality, these are national problems. Every state is challenged with it. Mississippi faces greater challenges.
We started out with a simple goal. Our goal was to eliminate preventable maternal and infant morbidity and mortality in our state and improve the health of mothers and babies in Mississippi. It's just a small task, but we believe this is the best group who can take this on, and we're so glad to have you as partners.
As a state, we are now working really hard to try and implement those practices and interventions and programs that we believe are going to improve our outcomes. It's a greater challenge here.
We cannot talk about improving those outcomes without talking about access for the mom. When she has access to medical care and she is aware of her preconception health and takes care, not just knowing, but also taking care of herself prior to pregnancy, we will be able to optimize outcomes for the baby. If her blood pressure is well controlled, she's unlikely to go into a crisis. If her blood sugar is well controlled, her baby is less likely to have malformations or be at risk for death. Those are all things that will, if taken care of for the mom, impact the baby.
As you can see, the Dopplers are normal, which lets you know that the blood flow to the baby is actually normal. And then also
the best way to have a healthy pregnancy is to have a healthy mom in the beginning. And if we're not focusing on that, if we're not doing the preventive things that we need to do to be our healthiest at the time that pregnancy occurs, then we can't really expect that the health is going to begin with pregnancy. That needs to be present before pregnancy ever happens.
Approximately 60% of babies in Mississippi are born with Medicaid insurance. The babies stay on the plan, but the mothers lose coverage 6 weeks after birth.
That care ending kind of at the end of 6 weeks doesn't adequately cover some of the risks we see in mothers, but thankfully, during pregnancy they're covered and then the babies are covered. Those who want to see this be a place for babies to be healthy should really care about moms and care about our outcomes for every mom.
But many promising things are happening in Mississippi. With a grant from the March of Dimes, Jackson State University is partnering to improve African American women's health. UMMC is implementing a quality improvement model to screen mothers for 4 risk factors. The Mississippi Perinatal Quality Collaborative advances best practices for maternal and infant care across Mississippi in an attempt to improve outcomes and reduce disparities.
50 people from about half the hospitals in Mississippi. Now we see.
Every year we hold an annual meeting in Jackson inviting hospitals from across the state, nurses, doctors, public health advocates, and family advocates to, in part, learn about what those best practices are, and then decide as a group, what are we going to work on as a state? What are the things that we can improve? When a baby needs resuscitation, we should have trained people in every facility. When a baby gets care who's addicted to opioids, every baby should have the best access to care if we know what to do.
I think moms can ask themselves that question. Am I doing everything I can to be the healthiest that I can be, to have the healthiest pregnancy possible? But I think it's also really important for us as healthcare professionals to continually challenge ourselves to be our best. And that also means by questioning our own, being insightful and looking internally to figure out if there's something that we could be doing better.
What the actual normal heart rate that you're gonna have looks like?
Maybe 6 months after Jordan passed, I sent an email to Dr. Famuti at UMC, and I told her that I would like to be involved in some kind of way. But I knew that families needed support while they were there. We took those ideas, we asked a few people for their input, we did some research on best practices and what other NICUs were doing, and we formed a family advisory board. We've designed a NICU journal for the parents, so where they can record their baby's first weight, the first time their baby took a bottle, the first time their baby smiled, just different milestones.
Anything they ask me to do, I do it.
Keisha Flanagan has become a big supporter of the March of Dimes.
We were the ambassador family last year.
Charles Johnson has promoted federal legislation and begun a foundation.
For Cure for Moms is a foundation that I started to honor my late wife, Kira. We want to raise awareness about this maternal mortality crisis. The reality of the situation is the majority of Americans aren't even aware that this is America's dirty little secret. The United States leads the civilized world in women dying from preventable causes related to childbirth, first of all. Second of all, we want to be able to support these families that have been in similar situations. So we want to provide resources for families that have lost a mother.
I love you.
One of the things that we do in healthcare is we speak in generalities, and we believe that women know exactly what we mean. I am far more specific about my counseling than I probably have ever been. The other piece that has really changed, and it was probably more about my husband than it was about me, when emergencies come up, or if we are anticipating an emergent situation, I try to explain as much as I can. Even when things are getting difficult, I try to make sure that people understand. I try to make sure that I'm eye to eye with the patient. I need you to look at me. This is what's happening. This is what we're doing.
And it's heard your heartbeat every day.
For me as a pediatrician, that's what matters on the long term. It's not just keeping them alive, but making sure that they have a meaningful life on the long term. They become people who contribute to the society.
My hope is whenever I share Kira's story, is I want people to see beyond the data. And I want people to understand that these are precious mothers and these are precious babies that mean something, that mean the world to these families.
One baby dying is too much. One mom dying is too much. And we see it every single day. And that's a lot of babies and a lot of mamas that have to either grow up without their parents or without their children. And that affects you for life.